Jim will tell you a lot more, but just as chair of the trust, I tend to sit and watch carefully what's going on. We're really busy. Patients are at our heart, and patient safety, and that's just drives us right through everything we're doing, being no doubt about that. But we're under pressure, there's no question. COVID is still around, and as you'll find out from Jim, it's quite a different impact at this point in time on the trust, and it's really quite difficult for us. The staff are tired, but they're absolutely committed, and I think you'll hear from the board walkabouts. Invariably, the staff are positive, smiling, and actually quite cheerful, but you can see in their eyes they're quite tired. There are big things around us, energy costs, inflation, the Ukraine, all of that is around us and actually influencing our lives inside and outside of the trust. But we're driving on with a lot of care and a lot of thought. There's a lot to do in the trust, not just in the moment, but actually making sure we've got that future that we're still building and planning on building. So that's where we are from my point of view. But more importantly, we need to get to what Jim and the executive team are reporting to us. So
thanks, Alan. Can we load the dashboard, please, Laura? So I'm going to just talk briefly to the dashboard, pick up on Alan's couple of additional points as well as we go through. There'll be a bit of a theme as we go through the agenda items. So first of all, strong performance relative to the rest of the NHS. So still the country's best performer on most of the main metrics. Continued tension where we're not quite where we want to be in this last couple of weeks. So this report's at a different period, but the last couple of weeks have been incredibly difficult again with increasing COVID prevalence, albeit lower impact disease, so it's a milder version and with a vaccinated population, but largely the impact on absence and disruption where either staff are unable to attend last minute, which has disruption through clinical pathways, or patients are unable to attend because they've found out they were COVID positive on the day of attendance, etc. And loads of complexity associated with that we're just having to work through again. I think we can expect another 2 to 3 weeks of that being quite difficult, and then hopefully get into a rhythm that feels a bit more normal again. I can't remember how many times I've said that, but eventually it will be true that we'll get back to normal. We have a very limited backlog relative to other places, which is so there's three things that really stand out in discussions around the country. One is the backlog, and our backlog will be largely eliminated within the coming weeks in terms of long waiters, especially in terms of restoration of the whole waiting list and activities will take a few months longer than that. Urgent care, where there is huge pressure, which you'll see in the performance report Bijou will talk to. And discharge is a huge issue, which thankfully, because of our local arrangements, we don't have big problems relative to other areas, but there's a lot of tension, and especially when COVID levels rise, it has an impact on all of these metrics in terms of the broader workforce, and makes it harder for patients to move through their pathway, etc. So we're in very good shape relative to others, not where we want to be. We need to be really focused on our staff and patients as always, because as Alan said, people are very tired and fed up and confused about the rules. So we just need to help people through that transition. It does feel weird that we've just clicked through the 2-year mark, and yesterday was a day of reflection, and we've got a remembrance facility here owned by North Tyneside Council, not far from this building. I would urge people to just spend a bit of time and think about the last couple of years as well. And I think on that, just our staff have been fantastic, and the public have been fantastic and with us throughout. So really, we should remark upon that. You can see a spirit of that through the walkabouts and other things. And then finally, as a last public board meeting for Anne Stringer, who's retiring at the end of this month. Just wanted to publicly record our thanks for Anne's contribution over 250 years. We stole her from the private sector in 2004. Absolutely sure she intended to stay a couple of years and then escape again, and we managed to avoid that. And also Claire and Annie are escaping to the ICS soon, so it's their last board meetings, and would like to record again publicly thanks thanks to them for their contribution over similarly 200 years each. So, thanks for that.
Thanks, Jim. I'm sure the whole board echoes your comments about those three for their fine service to the trust. We'll miss them. Can I challenge your dashboard a little bit?
Mm-hmm.
2 red dots, children and young persons,
Yeah.
and the cancer 62 day.
So on the cancer thing, first of all, we had a bit of a regroup with our management team about 3 weeks ago, Alan, because cancer is one of those things where you just got to be on the ball every minute of every day. And I think largely because of the absence through the December, January and the February period related to COVID, we've missed a lot of diagnostic slots. People couldn't attend, clinicians had last minute absence, so we dropped our performance a little bit. We've had a major regroup. There's significant improvement in the last couple of weeks as a result of that. Being very granular about managing individual patients through every step. So we should see improvement, and we need increased visibility on this through Finance and Performance Committee and other places. We're all worried about lots of things related to COVID. I think I'm especially worried about 2 things. One is the impact on young people, especially young people with mental health services, which is pressured across the country. I think, frankly, access is disgraceful around the country, and we need to do more to have a very broad view of embracing those people and support them as quickly as we can. And Bijou and other colleagues are working on that to improve access, and it needs to be more visible in the dashboard. And also, we should be also concerned about the impact on very old people and the impact that lockdowns had on them, deconditioning and isolation, etc. So we're worried about everybody, but I think we need to find a way of reflecting all of that in our plan and then subsequently in the dashboard, and I'll do that from next week.
Thanks for that, Jim. And it's good that the red dots work and bring it up for you to comment. Any other comments on the dashboard? Okay, so if we can move on, it's still you, Jim, I'm afraid, it's in planning. So it's item 2.1.
So Bijou's going to walk through the detailed slides. I just wanted to kick this off really in that there's a few things that we need to bear in mind whilst we're doing this. We've got national planning guidance, which we've got on Christmas Eve. We've discussed before here, and largely set out an expectation to get to a point that we have already passed in terms of our performance. So there's very little stretch in terms of performance and improvement in the national expectation, which reflects the shape that we're in pre-COVID and the efforts over the last couple of years. So that's a good thing. The risk of that is we don't stretch ourselves enough and we'll lose ambition. The elective plan does bring some new challenges for us, and we heard last night with governors some of the outpatient work, for example, where we've got significant opportunity to fundamentally change how that model works. So I think there's something really interesting but very complex for us to deal with in all that. And there's also there's going to be a range of national things dropping out around cancer ambition and strategy, and urgent care eventually. You mentioned discharge and stuff as the ICS and place collaborative sort of take shape, etc. So we're working in that context. When we consider our plan, I would just say let's really try and think about from our own point of view when we shouldn't be aiming to hit national standards because we've been comfortably delivering. Let's go beyond that as usual and try and create the space and headroom to drive innovation and to really think about the things that we've learned from in the last couple of years. So we're not at that position yet in the planning process. So in a normal year we'd be signing off a final plan now that we're all comfortable with. We've submitted the plan into the National Regulatory System. It's largely complete from that point of view. Our like board in April and May to spend more time thinking about the stretch, the ambition, the resetting of the clinical model, our ambitions around community services and home care, those sorts of things. And also then just try and get the balance right between how we've got that ambition and realism about deliverability in the right place. Because the danger is we just can't click through the technical stuff. So work in progress. Bijou will talk a little bit more detail now. We'll come back and have a proper conversation next month. And I think we should set ourselves the objective, which feels odd, but let's set the medium-term plan by about the end of May, knowing full well we're going to start the year and be able to largely deliver the things that we're expected to deliver. Okay.
Yeah, Region.
So just in terms of the Trust's overall plan, so it's the one thing to note, it is the last year of our 5-year plan. So we did refresh some of our 5-year plan goals last year, 21-22, and that was in particular with regard to the partnership agreement, our focus on digital, and our move to really have a push on some of our more areas of innovation. But I think it's worth knowing, and we're saying this throughout the organisation, that it is an opportunity as we head into next autumn in particular, but to start thinking about it from now, about what the next 5 years bring for us and bring for the organisation. In terms of the national plan, as Jim's alluded to, the next 3 to 5 years is still to be confirmed from them. We do know there will be some additional planning guidance that will come out, for example, the cancer plan, which will change some of the metrics we've historically worked to put a focus on slightly different areas. That we're waiting, we've got some kind of preamble in terms of understanding what might come out, and we're aligning ourselves to some of that to see what our performance would show within that. And there's probably quite a bit of work to do as that gets fine-tuned and released. And I think it's important to understand as well that, and I know this feels like it's very obvious, but we entered this last year of our 5-year plan on the back of 2 years of COVID. So the environment we find ourselves in, both from our staff, our local population, how they access healthcare services, is different to some of the things that we've historically used as markers in the sand. So in terms of some of the highlights of the planning assumptions that we've made that do match some of the national guidance, we have said as an organisation we've assumed that we will not use any independent sector capacity. We haven't used that up until now, and our plans aren't based on using independent sector capacity at all. We have said that we would look to meet the standards that the national planning guidance requires us to, and we'll flip forward into some of those measures in a moment, and that we would increase our activity in line with the national planning assumptions. We have also assumed as part of our plan that there would be no significant rise in COVID numbers again, as per what we saw in the first wave of COVID. But obviously we will keep a close eye on that in terms of some of the discussions we've already had this morning. So in terms of the national performance requirements, we already meet a number of these measures, and so as you're aware, we discussed at the last board development session about how we aim to go further, faster. So for example, the national guidance would suggest that by March 25 we would have no 52-week waits. As an organisation, we will be aiming to have no 52-week waits by the end of April this year. We've already reduced significantly, and I think had planned originally to have no long waits by the end of March, but COVID, I think, has played a part in terms of both patients coming forward, but also from a staffing point of view. And similarly for the 62-day cancer standard, there is a requirement for us to hit pre-pandemic levels by March 23, and again, as Jim's alluded to, that's not something we're looking to do. We're looking to do that a lot faster than that. And similarly around emergency care, we're waiting for the final, I'm going to say inverted commas, new metrics to come out, but we are very actively up until that point managing along the 95% standard, and that's what we'll be continuing to work towards until anything further comes out. We've also, through Safety and Quality Committee, agreed our safety and quality priorities. These do match some of the national measures that we're being asked to look at. So for example, ambulance handover, it's in the national guidance around a zero tolerance for ambulance handovers of greater than 60 minutes. So we have played that as part of our safety and quality priorities, along with other measures that we have seen in our own data, for example, medication errors in the community, that we feel that there is room for improvement on and will have a huge safety benefit for our patients. We have done, as you would expect us to do, a lot of engagement with managerial and clinical teams across the organisation, and there's a number of measures there that people have highlighted as seeing as critical success factors. So ensuring that we've got a very engaged workforce, how we grow and develop our own, having a clear focus on performance. You'll know from previous years we've had a strong focus on our digital agenda and actually a requirement to deliver on that digital promise. And I know Andrew would probably be wanting to come and say in here that that would be digital and our data promise and our data strategy, and that forms part of that. We've got a significant capital plan that's in place. And we'll continue to develop that and prioritise. We're going through a routine now of prioritising our capital plan. And I think in amongst all of this, and you'll see this in the next slides as well, our ability to maintain flow on our emergency pathway is key to being able to deliver a lot of these other things. So I think Simon and Elliot, two of our business unit directors, are joining later this morning to talk through our winter plan of what worked well, what perhaps didn't work as well, as we go into really trying to finalise what our winter plan is for 22-23 in the next couple of months. I think there's some things that we've learned through COVID that we're keen to keep, so this ability to have remote meetings where possible, people to be able to dial in. Our agility, we've learned particularly between the elective and the emergency stream, to be quite agile in flexing capacity, and we want to build on that some more. And then some of the infection control procedures and processes that we put in place, the hand washing, the mask wearing in clinical areas, very keen to keep that, as well as some of the outpatient changes that we have already put in place on the back of COVID that we want to develop further. So finally, just in terms of key themes, and you will start to see this in our comms that goes out throughout the organisation, key elements for our plan moving forward, and you'll see this if you read the operational plan and the business unit appendices, this flows through all of those. Capacity, flow and load levelling, so that is particularly between the emergency and the elective flow of work, our continued focus on our community and social care innovations, some really exciting things that will hopefully come to fruition over the next few months that will help that flow and capacity. A big element of our capital plan, our population health focus and work on inequalities, looking after our people both in terms of our staff and our local communities, and getting back into a new rhythm of working. We've always talked about being able to work at pace, but having a continued focus in terms of delivery and maintaining a rhythm of working. We've had a lot of engagement with business units, both in terms of business units going down within their teams, but also across, to ensure that any cross-purpose working across the business units is maintained in those relationships. One doesn't do something that's going to impact on the other in a negative manner. We're happy to take questions.
Good. It says discussion, so can we discuss? Colin?
Questions?
That's the invitation. Questions? Microphone. Jeremy?
I mean, the ambulance handover bit is going to involve, I'm sure Elliot and Simon will cover it a bit, but I know EKIST are coming in.
They're coming in the end of the first full week of April. They're doing 3 days with us where it's a series of observations between ourselves and they're following, in inverted commas, NIAS as well. They have had some good conversations with them already. They recognise that when you usually have ambulance handover delays, there's no silver bullet to it, and it's usually across a system and organisations to solve together. So I think that's why they're doing the dual approach in terms of NIAS and ourselves. I think the team are very open to, it's something we've been grappling with for some time, and we have made progress definitely from where we were, but I think they would welcome a fresh pair of eyes really to have a look at what else could we do that would make a difference. And I think which is why it appears in the plan, you will already know that a big element of that is also flow out of the department to allow new patients to be welcomed in.
It's a thorny issue. I'm glad you've said that we're all working together on this, although sometimes it doesn't always feel that way.
I think as well, and I probably should just say this, they will look at how, I know it's not about necessarily the data, but they will look at how the data is captured, both in terms of the PIN transfer, but also trying to look at it in its entirety, because currently they only measure what comes in through the emergency department, but they don't measure delays that might exist elsewhere across the patch, and that's something that we do want them to look at, because what you don't want to do is fix the bubble in one place, it to pop out somewhere else, and nobody's measuring that where it's popping out somewhere else, because actually that's just as detrimental to the problems being at the front door.
Okay. Yes, Alison.
It's on a similar theme to Jeremy. It's clearly an issue because it stands out in terms of some of the regional reports. But I suppose within the region, I'm quite keen that there are two issues, and we've just been around NSEC, Rich and I, and we're talking about this. There is a bit where, if we think about ambulance handover as taking a critical resource out from where it needs to be in the community, it's really important that across the region, I think, that people who are waiting to offload patients for a medical admissions unit or a surgical admissions unit in other trusts at the moment are hidden. And if I'm worried about the impact of ambulances across the board, there is a bit where I'd be really keen that we could actually look at that, because otherwise we're shining a light on something that we need to solve internally, that the shining light is not shone across the region, because this is a regional issue, and the patients that suffer it potentially we need to make sure that we're not kind of apples and pears and not counting one thing in one environment and counting it in another, which I think is really important. And I suppose coupled within that is how we make sure, and again this is a regional thing, that we get proportionality within this, because the number of ambulances that we receive relative to the size of the ED department, looking at the figures, it appears to be slightly disproportionate. So I think we need to fix our own bits, but there are bits that are a wider discussion than even just NIAS that need to be sorted within that. And I am slightly worried that you can count things and actually it's the ambulances on the ground that really matter. And I'm slightly concerned that there may be slight hidden things that are exposed to us around the kind of medical and surgical admissions, where if you're in a delay there, it doesn't count as a handover delay.
Yeah, important point. Jim?
So I'd agree with all that, and I think we just need to make sure we solve the right problem as part of all this. So it's in absolutely nobody's interest to remove one bottleneck and replace it with another one. That might be even more difficult or dangerous. So we've got to fundamentally look at capacity in the round and make sure that patients get where they need to be. It's complicated, it's always hard. We need a reset again now because of what's happened in the last few months to get everything back in the equilibrium. But let's not try and chase something that actually doesn't address the issue from a patient or a clinical perspective. We've got to try and deal with this thing in the round and make sure patients aren't waiting anywhere unnecessarily to get what they need.
It has got a national profile now, which will help, I think, a lot.
Absolutely.
I mean, Alistair's point about regional partner trusts being ready to play, very important.
Yeah, we all get, we're honest, we all get very tense with each other when we find blockages and bottlenecks, and everyone, in those times of extremis, we all feel like we've taken an unnecessary burden because somebody else tried harder. We need to acknowledge that everybody's under pressure and the whole system is out of sync. We need to put it back into sync together. Again, there's no point in one of us solving this and another hospital nearby hasn't, and we just all can't try and compensate for it.
Okay. That's what I call headroom for improvement, isn't it?
Yeah.
Yeah, any other comments back to the issue? Good presentation. I think the point I notice in all of this is it's a lot of words, but actually when you look back, we do most of them. We maybe don't do them quite at the pace we hoped, but actually we do get through it, and that's amazing. Sometimes it's a full 5 years. But other times, you're seeing stuff happening in 3-4 months, which is really, really good. Right, anything else for the issue then? Watch you. That's very much. Right, we've got cyber resilience is the issue again.
There you go. It's just a very quick verbal update on this. So there was a note that was previously circulated to board, and this is really just because it needs to come through Trust Board in a more formal way, and it's to advise that we were asked, following the Ukraine incident, at the time it was the tensions that were rising at the time, we were asked to put through a number of patches through the organisation. Everybody, I think, through NHSX and NHSD were on high alert, and it's to confirm that we've done that, and we are continuing to monitor very closely any activity that's coming through. So the security team are on high alert as a consequence. Within the organisation, we've also agreed through EMT that we now have, I'm going to call them cyber alerts, so cyber levels in terms of 1, 2 and 3, just so that the organisation can understand up front that if one of those alerts rise, in the same way there would be a terror alert arise, there are certain actions that take place as a consequence, and as an organisation we would expect our teams to work in a slightly different way because certain things would get switched off. So it's about making sure that people, one, are aware that it's not, when it comes out in terms of the comms, that it's something that's serious. 2, there's a consequence and they know what the consequence is going to be, and so they've got mitigating plans, how we can still continue. And the emergency preparedness team work very closely with Dave and the team to ensure that's in place, and hopefully we won't get to that point where we hit critical level.
And I think last night you referred to the fact that we have been under attack for the past several weeks, mostly around the Ukraine stuff. So it's going on all around us, but we're defending well. Any comments on that? Andrew?
Oh, I might just add around sort of the context of what Bijou said there, is it's been a pretty tough few months really from a cybersecurity point of view, just in terms of the number of incidents that have been and vulnerabilities that have come out. So I'm talking about at a global level, not just for us as a trust, but the whole industry is being buffeted around quite a lot. So I think just recognising that the team's done really well under that pressure and keeping the delivery going at the same time as keeping us safe. They've done a really great job. So I think we recognise that. We recognise it's a really good team that's there, but there's also a business case going through looking at the increasing the size of that, and we're always looking at the tooling that they need. So that is all being assured through IM&T committee, but it's just to say really well done to them in that global context that we're in, even before Ukraine happened.
Okay, that's good. Yes, it's not just about Ukraine. I mean, we're getting ourselves into a really robust position. There's always more to do. Okay, anything else on cybersecurity? We'll come back. Right, we're going to be joined now by 2 business unit directors, Elliot Sykes and Simon Eaton. Update on winter. I think you're joining us online, both of you.
Hi, I'm certainly here. I'm not sure. I know Elliot. Sorry, I'm not with you. I'm Elliot, so I can see him. Elliot's on critical care, and I'm in clinic. You'll be pleased to know we're working as doctors as well today. So we're due to give you a winter update. If we can just move to the next slide. And I guess I just wanted to start off by really emphasising that we're using the word winter in inverted commas. As you can see from the slide, they're looking at the kind of 4-hour wait as a marker of, and I don't think it's about ED, that's just a marker of pressures in the system. It's been a difficult for us since July, which is often a difficult month actually, but then it's really not relented at all through the autumn, winter, and I guess part of the premise of there being a winter is that there's a summer as well, when we take opportunity at least to catch a little bit of breath. And certainly with pressures in ED this morning as another signifier, we're definitely not in that place currently. So what I've done is I've just produced this slide to kind of map a few things on top of each other. So if we can just do the next bit, please. So this is the attendances over the last couple of years, and you can see obviously some of the drops in attendances that happened with the various lockdowns and things that we've had, but you can see that from kind of summer of last year, those attendances have been higher, and I think certainly eye of faith can see that they're probably consistently a little bit higher than they were before all of this, and that graph starts with kind of January, February 2020, before a pandemic, but a winter which we would have said was a difficult winter back then. And then if we can put the final bit on, what we've also mapped onto that is thinking about COVID. Okay, and previously when we've had significant levels of COVID in the inpatients, that's coincided with times of reduced attendances because we've been in lockdowns. And what we're trying to do at the moment apparently is live normally with COVID. So we have got this overlap between the pressure of a winter and high attendances, but actually also significant numbers of people with COVID in hospital. And if we can bring the next slide up, what that means is this overlap, sadly, means that we've got recurrent problems with outbreaks on the ward. The good news from that is that this is different, so that people aren't, we've done a little bit of work looking in the last couple of months. There have been a lot of people in hospital with COVID, particularly the people that have caught COVID in hospital. Very few of them have died as a consequence. They may well have had their stay extended, they may well have had the wind taken out their sails, but this isn't as deadly a condition as it was a year, 18 months ago. But it does have a significant effect on slowing the whole system down, on closing beds to prevent other people catching it, etc. We've obviously had some very consistent and prolonged problems with staff absences, which gets very tiring for everyone involved, because we've just used up every idea of favour around kind of covering that, and that isn't showing at the moment. That's getting worse again rather than anything else. This also hits our colleagues in the community and social care and community services. So we had very significant delayed packages of care, which usually, in fairness, isn't a big issue for us, but certainly has been this winter, and delayed discharges because of ability to get to a nursing home, or my wife's vulnerable, I prefer not to be exposing her to COVID, etc. So it's been a bit of a perfect storm, if you like, of all the things that you could imagine you want to go wrong consistently are causing us pressures. The good news for the next slide is that actually, as ever, in a sense, we are still performing better than elsewhere. So that's the regional comparisons. And if you just add the final bit, and if you look at the national table as well, so for the next slide, next animation, that shows again we are quite considerably at the top of that as well. So it's a familiar line, I'm afraid. We aren't where we would like to be, but we are a darn sight better than anywhere else. So that's kind of the current situation. One of the things that really helped us, and as I pass on to Elliot, thank you to Elliot and his teams for this, is that in just at kind of the turn of the new year, and for kind of 3.5 weeks into January, we were able to use Ward 3 at Hexham, which is one of the elective surgery wards, which added 20 extra beds into our system. And that was a huge help at that point, to just give us a little bit of extra space that coincided with very high levels of COVID right across all hospital settings. And actually, we had some of our best performance in that month, in recent months. But that was a huge help. But that's another indicator a little bit of our the stop valve, in a sense, that we're using, that we need to think about for future years. And I'll come back to that in a minute, but I'm just going to hand over to Elliot for a couple of slides.
Okay, next slide, please. So just linking to Simon's comment there about the stop valve, this slide really just reflects how flexible we've become working between medicine and surgery through surge periods. And these are all the options that we considered for that surge 3 to 4 week period. We just go to next animation, please. And it was really about striking the balance of the ask, if you like, of offering up additional capacity and staff, with half an eye on the impact on the elective programme. And at the bottom there, Ward 3 at Hexham was the option that we went for, because we felt it sort of ticked those boxes from a surge capacity perspective. I'm not going to say the least impact on elective surgery, but less than some of the other options. Next slide, please. And we predicted that the impact would be around 25%, but with a lot of work, we moved a lot of things around. So we think that overall 170 patients were impacted, with 80 of those being cancelled, but 90 being moved to other sites. And in the sort of opposite direction, if you like, we moved 120 day cases to the Hexham site, with a small number refusing to undergo that move. And then there was the COVID component, if you like, with cancellations due to no staff or surgeon, and then because of patient reasons from a testing positive perspective. So I think overall, on the grounds that we do about 1,800 cases a month, we were able to sort of mitigate that predicted impact of 25% down to about 10% for that period of time.
So thinking, as we always are, about, okay, we've got to get through this one, and we're definitely not out of winter yet. But thinking forward into kind of forthcoming winter as well, hoping we get a considerable summer in between. We are doing some work at the moment thinking about bed configuration. You may well be very familiar with the idea that, and the graphic on the right hand side, which you might have difficulty seeing, but we on that particular day, which was a week or so ago, there were 89 empty beds across the system. They were primarily some of the elective surgery beds that we are very currently very protective around those, and they're not necessarily available to use in the emergency streams at that point. So we're doing some thinking about that. We've got another meeting this afternoon to what that should look like going into the future. That needs, from a medical point of view, certainly the flexibility or contingency. So either we need to be able to use those beds and flex into them at times, or have the contingency like the Ward 3 thing, that when we get into pressure points, and I think some of that is predictable around kind of that post New Year into January period, but also kind of less predictable, as in kind of actually, to be honest, where we are currently, we need to be able to kind of understand how we're going to kind of get ourselves out of those troubles by release valve a little bit, and doing all the other things very well, but whilst protecting our elective delivery, which is obviously a really important part of the overall business. A lot of that is thinking about this idea of right person, right place. So we've got our same day elective care, ambulatory care. A lot of people go through there, and that is again one of the largest units in the country. Thinking about the urgent treatment centres, thinking about what doesn't need to necessarily be seen today and can be handled in a different way. So it's seeing the right people in our emergency departments and in NSEC. Thinking all the time about flow and efficiency and how we get the best out of the systems that we've got, that again are good, but we just need to kind of constantly be improving those and getting that, and the amount of work that's going on every minute, every day, of trying to kind of see these things through is really important. And also, again, thinking very positively about our discharge arrangements, partnership working, moving to kind of think a little bit about social care and care homes and other sorts of things that's just going to help us make sure that that's effective as possible. And then finally, I guess, just to kind of, you'll be aware, you can imagine the strain of the last couple of years, really not having a summer last year. What people didn't have is a summer holiday either last year. Hopefully that will be something that's more positive this coming year. But we just really need to look after people who are really at the lowest of their ebb, I think. But we still keep having to ask them to do more and keep going. And we need to look after them as best as possible. That's the last slide from us. So any questions? And thank you.
Switching Alexander.
So I think that was fantastic. I think it gives a real feel for the level of flexibility and agility and the complexity that's going on, and it's never over. So I think just emphasise doing this again now, trying to get ready for the next tricky couple of weeks, and it'll have to happen all the time. It's just a feature of people's lives, but colleagues do it very well. As you mentioned earlier on, load levelling in the planning thing, and Simon showing the infographic on occupancy. And just to bring that to life, we've got enough beds overall, as most organisations, but they're often in the wrong place at the wrong time for the specific kind of patient that you need to get into that bed. So we're just going to have to reset that again for a while and accept that in a year's time that we'll be wrong again, because things change, and it's how we respond to that. I think it's very important. And then just when you're talking about Hexham, I think Elliot was talking about patients moving to Hexham and stuff. It's very easy to think about this from my national role. We talk about moving patients around all the time. We discount this when we're moving large numbers of people 35 miles, 45 minutes away from where they normally are. It happens all the time with great patient engagement and interaction. There's very little unhappiness from the patient perspective. They're just happy to get the treatment and getting it done in a fantastic facility with wonderful staff, etc. But it's actually not that easy to do. We've become good at it since 1998, but it's a long time, isn't it? So, moving patients around in that kind of volume with that kind of system, I think takes a hell of a lot of skill and a team need to be really commended for it.
Absolutely. Alan Craft?
I think Jim has partly answered it, but it lacks some facts on it. This question of patient satisfaction and even staff satisfaction, all this juggling about moving patients and staff around. I mean, is there anything in Annie's survey which reflects that, it's either better or worse than it was before?
So Annie will answer properly. Staff generally like getting moved less than patients do, oddly, I think. So we'll probably handle the communication better with patients as we've learned lessons over the years. Generally, staff don't like getting dragged around, especially last minute. They'll do it for short periods, but it can cause problems longer term, which is why we need to really address that load levelling thing and make sure as best we can we've got the capacity in the right place, so we aren't pulling people around all the time. But Annie, I don't know whether there's any more to add to that.
Yeah, Alan, I'll have a chance to talk to it later with the data. I think where we see it is mainly in the team working data. That's taken a hit because teams are being reconfigured all the time and you're not necessarily working with the same colleagues, or the people that are being moved are joining an unfamiliar team at that time. So definitely that's been felt. Definitely we've seen a dip in overall satisfaction, but probably not at the level that we might have imagined. Marion described in her safety and quality report that January was the hardest month on record for a long time that she can remember, and given that we did all of that real-time measurement of staff experience in the toughest month of January, I think it speaks volumes about the resilience of staff, but certainly it's there, and you've seen a change and how hard people are working, how tired people are working, and how much people want to be part of a familiar and consistent team is definitely in the data.
Thanks, Annie. I've got to accuse Marion, Jeremy and Visual. Alan, did you have a...
Well, it was just, you were talking mainly about the staff there. I mean, are the patients just happy to get treated wherever they?
The dip is more evident in our staff experience data. It's not in our patient experience data.
So I think there is actually, I'll pick up another time properly, there's quite a lot of research into this, Alan, and generally it rests on a couple of things. One is, if the communication happens at the beginning of the pathway very well, patients will move and they're happy to. Very understandably, very hard to move when they're already in a pathway and have an established relationship with a clinical team and a site. So moving people around from that perspective is harder. I think we learned this in the early days, and I think the initial communication is handled incredibly well. But there's some other stats that we can share, another point about how movement affects confidence and impact on patients.
Sorry, Simon, you're going to come in now, aren't you?
Well, I was just going to add to that I think one of the things that we're moving and people not being in the right place is actually quite a common thing. So we've often got people who lived in Wallsend or Wansbeck and other sorts of things like that, and that's just part of the reality of just trying to keep things moving. I think there are two things that we learned over the winter. One was that actually it does have an impact on discharge, but we work quite hard to cross lines if they're in Northumberland to work with the North Tyneside teams. I think the other thing in our benefit was that visiting just wasn't happening. So it didn't make a huge amount of difference to daughter that mum was at Hexham rather than in Wallsend because they couldn't visit anyway. I think it would be much more difficult for a prolonged stay if visiting was anticipated to be a normal and you were having to drive 45 minutes or more to go and see your mum. You know, if and which would what would have been your expectation. So I think we might have got away with it this winter, but I think that's relevant to us planning in the future, whether it's a Hexham, Wansbeck or North Tyneside release valve, if you like, because of that potential convenience of being a bit nearer to the main population base we serve.
Good point. Lauren?
Yes, so thank you. So just really to reiterate what Jim was saying earlier, we didn't have many complaints at all from patients. I think this was down to the way it was done. So Bijou, Simon, Elliot and I met very regularly before this happened to go over all these options. And the reason that we chose Hexham really, one main reason was to keep the team together and to stop the travel.
Yeah.
Because these are the two things that, as Annie says, they concern staff because they're going to new areas. They stayed in their same area. But the other thing for us is that it was communication at the very beginning to make sure that we got everybody on board because they were the users of the service. And we met with them very regularly. We went through everything and explained to them why. We did exactly the same with the patients that were coming in for their operation. Just to explain why we needed to do this. What patients say to us is that they would like to have their outpatient service locally, but they don't really mind where they travel so long as it's the consultant. So we did that, and then we monitored it every day and then every week to make sure that the staff were happy and the patients were happy. And Simon went over and he worked with Paul Edmonds, our doctor in Hexham, and that worked very well as well because they knew that they were going to get some expertise. The nurse practitioners joined in, and Elliot and I, as I said, kept in touch with them very regularly because it wasn't just the ward, it was obviously the theatre staff as well because they then had to move somewhere else. So it was a very good team effort from everybody.
Inspire, move. Jeremy?
So it's just really to make 2 points. One about the, whilst there's an impact on staff of moving, there's been an absolutely enormous impact in terms of the late sudden absence caused by the various different ways, and that's what really underpins an awful lot of it. It's been difficult to cope with. But it's just that we talk about winter and we talk about COVID like they're all the same thing, but the number of moving parts in terms of staff absence, whether visiting's on, whether elective recovery is going on, the various different variants has made each little element that so this is the period we're going through now feels distinctly different and challenging in different ways to January, to July, to the last year. And I think it's that constant innovation and needing to deal with that has been particularly tiring, that there's just new variations on the same operational pressures that hit the staff and the patients in the same way. And of course, what we carry on doing is seeing what's wrong with the patients, talking to them, diagnosing it, bringing them, getting them together with their families and getting them better. That's the whole idea, but we've just been doing an awful lot of it.
Good insight. Bijou?
It was really just to cover off what Marion had said, particularly around, I know one of the big considerations was about not breaking up staff teams, and the Ward 3 option allowed the whole team to stay together. We know because of all the things that people have already talked about short-term sickness, between Wansbeck, North Tyneside and NSEC staff were being moved around a lot to cover gaps, but this allowed the whole team to stay together.
It's a good interaction, the whole thing. So much learning in it, so much challenge in it, anticipation and planning, it's all there. But actually, on the downside, the movements and all the rest of it, you're aware of, and next time round, do it a bit better, which is what we do. Anything else, Annie?
Chair, it's just in response to Simon's point. We've taken an opportunity a decade on to redesign the real-time survey. The real-time survey really underpins performance on the ward, and we've seen when that was reintroduced, again, month-on-month improvement just on that feedback, getting to staff in a timely way. So one of the real focus on that survey now is around recovery and particularly restoring relationships with families again. So it hasn't featured as heavily in our surveys in the past, but it will be a new inclusion around how families are being involved at the level that individuals want them to be. And I think it's an important assurance going forward and into winter, connected to Simon's point.
Good. All right, are we done with that? I think, I mean, a tremendous presentation from both of you. Thank you, and good insight, even in the questions and comments. Thank you very much. Simon, I think you can stand down. We'll see you soon, no doubt. Elliot, I think you're on next.
Thank you.
Thank you, Simon.
Okay, thanks. Next slide, please. Okay, so update from point of view of surgery business unit. I'll start with the general update. So obviously we shifted quite significantly on Monday from a COVID de-escalation perspective. That's gone well so far. It's largely well received by staff, and there's been no real challenge at present in light of increasing COVID numbers. The robotic program continues to implement. We implemented into upper GI in February, and are getting quite close from an orthopedic perspective, which is a component of a research trial. We're continuing to work through the transformation program with personalised outpatients, and linked to that, the work with Bain is ongoing in relation to elective outpatients and the contact centre. And I have to say the relationship with Bain is really good and developing really well. We've got a number of estates programs which are listed there. The NSEC theatre estate business case is still being worked up, but a number of other programs listed there will start to come to fruition from May onwards. And then from a workforce and leadership perspective, Andy Moon is our new urology lead. I think that's a really important appointment from traction in what is a very challenging service at the moment in terms of urology, and Lena New from colorectal from a digital transformation perspective. And similarly, from a management perspective, we've got a lot of change going on in there, which we're currently working through. From a performance perspective, 18 weeks, you can see what the current performance is. We've got 40 patients. That number moves quite a bit on a day-to-day basis. Currently over 52 weeks. We're not going to hit what we'd wanted to achieve in terms of by end of March with no over 52-week waits, which is really disappointing, but we continue to work really hard on that. And I guess there's 3 layers from that from my perspective in terms of de-escalation, an ongoing sort of productivity component, both in theatres and outpatients, and then some individualised service-based work with Bain, working on some of our more difficult services. 2-week cancer is okay, but 62-day cancer is a real challenge across a number of specialties, particularly urology, colorectal and plastics. And I guess urology is a particular area of focus from my and our perspective. And you can see that there in the cystoscopy performance from a diagnostic perspective just below. And that's the virtual outpatient perspective, which we're just over the 25% target. I'll link some of those comments to a safety and quality perspective. I think the thing that worries me from a clinical perspective and a clinical risk perspective the most at the moment is the urology ASI list. That, if you like, is the equivalent of our differentiated emergency department queue. And we've got significant numbers in that list at the moment that we're working through with the urology service, and similar capacity problems in plastics. The colorectal and wider surgical team just completed a tabletop robotic colorectal review, which is at the 6-month point, but is also because we have had some complications in the robotic colorectal program. We're bringing that to safety in May. The initial impression is none of this is platform related and are most likely to look like complications that you would see in any colorectal service, but I'm awaiting the finalised report on that. We're similarly completing a missed cancer analysis because we've potentially had a spike in incidences from that perspective. So we're just completing analysis from that perspective in terms of any thematic issues. The new procedure business unit specific approval group is up and running. That's part of the actions off one of the Never events. And I was talking to Jeremy yesterday. I think we need to refine that process further, but it's up and running. And in terms of positives from COVID, and also linking to the previous BOA review, orthopedic SSO rates remain low, which is really good. We're continuing to try and recruit a mortality lead, which is one of our weaknesses, I think, in the business unit. We've got really good pockets of mortality review, but I really want to join that all together from a feedback and a thematic perspective. And Ockenden a significant ongoing piece of work, which I think will continue to increase and has a particular focus from a birth rate plus perspective at the moment. And then finally, allocate, we're slowly getting there. We're at about 80% now from a third level sign-off perspective. We had a really, going down to strategy and planning, we had a really good Trust Surgical Board timeout on Friday. The areas that we particularly focused on were flexible working and our sort of culture going forward in terms of learning from COVID and how we sort of get back to normal. A lot of discussions around elective pathway redesign. It's one of our focuses in terms of the annual plan this year, and we're really keen to move this on because I think there's a slight risk we'll fall behind if we don't. And a lot of discussion as well about elective recovery and elective recovery fund and what that 104% target actually means at an individual service level in terms of the individual components. And then finally about the digital strategy and within that our priorities and our capacity to deliver on that. As Simon talked about on the last presentation, we're continuing to work through the bed base discussion, and as Simon said, there's a further meeting this afternoon about that. And as part of the urology work, we're reviewing the urology service overall, including on the NSEC site. And we've got the next ACU Away Day coming up and really good engagement from a virtual ward perspective as well. In terms of finances, we're unfortunately about 2.5 million overspent, and CIP is extremely challenging, and we're 50% down on that in terms of our 3.4 million target. In terms of workforce, sickness is up. It's down from January. 2% of that is COVID, and we're there or thereabouts in terms of appraisals and some really important work from an international workforce recruitment perspective, some of which will map to theatres, which will be really important from an elective recovery perspective. And we're working through specific things like the specialist doctor role and going live in April with e-leave application. And then finally, from a patient and staff experience perspective, those are our focus wards, particularly NSEC 15 and Ward 10 at the moment. We worked really hard with the COVID de-escalation with a number of drop-in sessions with myself, the wider team and David Tate, really to answer questions that the wider teams had and allay any fears regarding what was a big change. Annie and others have started to allude to the staff survey results and the staff engagement results, and we've got some dips in surgery which you know, worried us and were a surprise. I think we know some of the reasons, but we discussed that again at length at the Trust Surgical Board timeout, and that's something that we're working through with Jacqueline and the wider team in terms of understanding and an action plan. And again, we've touched on staff moves, and that continues to be something that we monitor and focus on. And then finally, going back to the de-escalation, we have revised our visiting arrangements within the elective programme, and that's got really good engagement from the clinical teams, and we think it's the right thing to do. So overall, we've put ourselves down as a solid amber with those ongoing areas of focus in terms of performance, finance, and managing the current COVID climate, including de-escalation.
Elliot, thank you. That was a very thorough and honest appraisal and around your business unit. There's a huge amount going on there. Questions? I've got Jeremy and I've got Bob.
So I just wanted to say thank you for the getting in of those safety inquiries that you're doing into what's a very complicated picture, as well as the stuff you're doing on workforce. And it's probably worth saying, since we've had a bit of a conversation around COVID, I think the recording of absence in our senior medical staff is something that we're trying to apply some focus to. It's something I don't think we've got our processes quite right. We are introducing an electronic tool to help that, although I'm not convinced that's the complete answer to the issue. But well done, and thank you for putting all of that in.
Very well done. Martin?
In my view, Elliot, you're leading a very strong performance given the context we're operating in. I suppose I've just got two queries. One is,
Martin, microphone, please.
is it not on, is it? Yeah. It's on. Sorry, I wasn't close enough to it, Chair, forgive me. So my two queries, Elliot, are around those longer waits and how we're keeping patients well informed about, potentially when their treatment will be. And also, particularly think about the cancer stuff as well, around the issue Jeremy's raised generally about safety. So how we're monitoring those patients' health going forward.
Elliot?
Yeah, so I'll be honest with you, I am worried about the urology ASI list. It's about 900 patients. And if I'm honest with you, I don't think we truly understand all the clinical risk in there at the moment. We had a very positive meeting with Newcastle last week, and a number of the team are coming up this week, and we're just going to crunch through the list and understand that from a risk and triage perspective, so that we can, as you say, communicate with those patients rapidly and get them seen as rapidly as possible. So we are doing it, but at this point in time, being really honest, particularly in the urology service, the risk is currently unquantified in some of those patient lists.
Okay, that's honest. But we're on it and working on it, there's no question about that. Okay, any other comments? Back to Simon, Elliot. Really good. In depth, really busy. Thank you very much. Keep it going, Elliot. Okay.
Thanks very much.
Right, we're under the cosh a bit. So we've got regarding the safe working next, which is junior doctors and their activities against the requirements of the contract. Really important. Several years ago it was quite difficult. Right, Mike, your seat somewhere.
Apparently I'm just stand up.
Stand at the lectern. Okay, Mike, we're a bit under the cosh. I think.
Is that what I meant to say now?
Good to see you in person, Mike. Hello.
Oh, hello, how are you, Jeremy? Fancy you. Oh, there.
First time in a few years.
So the slides aren't up yet, but I'll start anyway. Do I need to do something?
Just click forward too.
All right. There we go. Okay, so hello everyone. 4 months since I was here, and no masks, so that looks like progress. I was masked up last time, which was lovely. I've just put this slide up again just to remind everyone, as if they needed any reminding, that we're still in the pandemic, and I think it's still having quite a lot of effect on certainly doctors' rotas, with isolation continuing despite us demasking and generally less things in the community around isolation. But it is affecting our rota teams and our doctor teams quite significantly. So I've just kept this slide in my presentation. But moving on, I'm going to dive straight into exception reports this time. We're getting a healthy number. We've had 252 so far this year, which is up to pre-pandemic levels. We had less in 2021, which was due to one quarter where we had very few at the onset of the pandemic. Not much change to the pattern. Almost all of the exception reports are in medicine. They're almost all for hours and rest, and most of them are resolved with time off in lieu. We've had a couple of hotspots, ongoing hotspot with exceptions in elderly care. We haven't fully explained them, but we have put some action plans in place. And over the last 2 quarters, there has been fewer exceptions, although they do still remain quite a high exception reporting specialty, and that's long-standing. What we did have at the turn of the year is a spike of exceptions in gastroenterology. Some work was done in the medicine business unit looking into why that might be, and it's highlighted a trainee in difficulty who's now getting a lot of support. I think that's a partial explanation. Gastroenterology's always had quite a high number of exceptions, but but we'll see going into next quarter when when the current juniors there rotate as to what happens. But I think there was a knock-on effect to other people on the rota who were having to stay longer because of a trainee who was struggling. So it is a partial explanation. And I think that highlights one of the good things about the exception system, that we can use it as a way of highlighting people who may need extra support, and that's what's happened in this case. Quickly on the locum spend, the data is more consistent than it was in that the same person sends it to me. The annual spend there's a typo, continues to be reduced as compared to last year, which is good. There's a slight change in pattern. I think we're using less agency staff than we were. It's more internal locum staff now. So my apologies, this is still up as Junior Doctors Forum. You might not all be aware that we're going to change terminology across the NHS now for junior doctors, and for my next report this will be Postgraduate Doctors Forum. So it'll be the PDF, not the JDF, which PDF's a bit unfortunate I think, but that's what we're going to have to be called. We will be open, whatever software you have. So it's going to be both. So we're doing them face to face now. We've struggled with the forum with attendance and really poor attendance since the onset of the pandemic, which I thought was recovering. But the juniors are really not good at coming in on Teams alone. If it's just a Teams meeting, I think they have difficulty getting access to computers during work time. So. And even going to the mess and trying to drag them through hasn't worked on the last couple of forums. But what we have seen, I've set up some drop-ins. I've got 2 weekly drop-ins now, and every month we have one of them at the main mess at NSEC, and there's good engagement at that one, really, because they can't avoid us. We go and sit in the mess and give them cake, and if you give them cake, they then engage. It's not quite as good as pizza, but it works well. So we have had some nice engagement, and it's nice to put faces to names for the people who I've seen doing exceptions. And it's just so much easier to resolve some of the issues, like some of the Christmas issues that some juniors had on a face-to-face basis. So hopefully we'll see that continuing. The newsletter, which I highlighted last report, the second edition is live. If anyone hasn't looked at it, it's worth looking at. Hopefully that's going to go from strength to strength as well. So we've got some nice engagement there, and some really good junior doctors, postgraduate doctors who are setting that up and running with it. So hopefully that's going to go from strength to strength as well. Rotas, no change here for us in that we are fully compliant with all rotas still. We've still got some relaxation of rota rules as part of the COVID response, and hopefully that will continue, because whilst, as I mentioned, things are less of an issue in the community for the public, it's still having a big impact across the rotas. Some rota gaps continue, and I think at the moment they're well managed. From a rota point of view, there's quite a big change going to go forward over the next 6 months or so. Medicine have put quite a lot of effort into looking at their rotas as a whole. They've got some senior clinical input into that, and hopefully that will, I don't know how innovative that change is going to be, but with the complexity of the medical rotas, it's just mind-blowing really. So hopefully we're going to get that sorted a bit better, and that will hopefully impact into junior doctors working as well. Postgraduate, I'm going to have to get postgraduate doctors ingrained in my brain somehow. And that's all I had really to report this time. It's a fairly quick report, and I'm open to questions.
Thanks, mate. I suspect you're a very good mentor to these young people. Jeremy?
The rotas have evolved complex. Mike has my 100, and Simon and all the team has my 100% support in trying to simplify them a little bit. But it is a very complicated system we run across 4 sites. And the newsletter has a picture of me in it. Good day. It's a very interesting article about what I'd eat on my deathbed.
You are this edition's celebrity. What was your meal, Jeremy?
Cheese and wine.
What was your meal? I can't remember.
Fried breakfast.
Fried breakfast.
Something I could trust the chef with because I assumed I'd be in Durham jail.
I think it's a good point Jeremy makes, though, that the simpler the roads and the less issues we have, with very few exceptions from paediatrics, few from obs and gynae, and those are very contained specialties without a lot of cross cover. So the cross cover and the complexity does impact massively into the working lives of the doctors.
It sounds a tough one. Okay, anything else to Mike? Mike, you do with great humour and I suspect very, very stylishly on the ground. So thanks for what you do. Keep coming back. Give us some good shit.
Thank you.
Okay. Right. Next item is the Ockenden review. This was covered in safety and quality, Alan. And Moira, I saw you both handle that.
Yeah.
Just while Jenna comes in, do you want to come in?
No, I mean, to be honest, we had quite a good discussion about this report because it's the review 1 year on, and Jenna will just go through some of the key aspects of that. I think we are expecting the second part of has it come out, Jenna?
Next week.
Next week, right. So, this is obviously the first part of the review and there's more to follow, which I have to say it gives us probably more to think about going forward. But so I'm going to hand over to Jenna.
Jen?
Morning everyone. And apologies to those who've already had the opportunity to see the outcome of the 1 year on review for maternity services. I know as a board you're all very well cited on the quality and safety of the services, but this just gives opportunity in accordance with Ruth May's ask the board to be cited on our performance in accordance with the 7 immediate safety actions. As you'll all be aware, phase 2 of the Ockenden review required that we submitted all evidence and data into a central national portal that was then evaluated by an independent team to provide assurance in relation to our compliance. This evidence was all submitted rather than assessed and has been reviewed, and outcomes are now going to be explored for each of those safety actions. Immediate safety action 1 was around enhanced safety, and that was around ensuring that you had an appropriate clinical workforce, as well as sharing evidence with the LMS and the Trust Board in accordance with the requirements around SI reporting. We are fully compliant with this action as the LMS have updated their interim reporting processes, and we are able now to share our training data and all SIs with the LMS to ensure that their quality and safety group have oversight of the activities within Northern Bridge Maternity Services. Immediate and essential action 2 was around listening to women and families, and at the interim point last year we were already fully compliant with safety action. We have very good relationships with our Maternity Voice Partnership, which is illustrated in the feedback from the CQC maternity survey that was published last month. And we continue to engage with service users to ensure that the pathways and updates in relation to maternity provision is co-produced with the service users to ensure it meets the needs and wants of the local community, particularly the focus on our equity plan. Immediate essential action 3 was around staff training and working well together. We had an immediate response following the pandemic in relation to a reconfiguration of our maternity training package, and we are able to demonstrate that all staff have received face-to-face training in relation to obstetric emergencies as well as fetal monitoring. We are reporting this data in relation to training into the LMNS as well as into safety and quality on a monthly basis. As I said, we maintain compliance despite the difficult staffing situations as a result of the hard work and the dedication of the team. Immediate safety action 4 is around managing complex pregnancies and the establishment of a maternal medicine centre within the region. The CCG at Newcastle and Gateshead now have the funding, and Newcastle Hospitals are hosting the Maternal Medicine Specialist Centre. We have really clear pathways for referral, which is illustrated in our clinical guidance to ensure women who have a high-risk pregnancy are referred into appropriate services based on their needs. This has all been audited on a quarterly basis, and we have demonstrated compliance to ensure that all women who require that specialist tertiary service have been referred and acted appropriately. Immediate essential action 5 was around risk assessment throughout pregnancy. In some ways, the most challenging aspect of maternity services is we currently don't have an end-to-end maternity EPR, and therefore the audit process to demonstrate that risk assessment has been performed at every antenatal contact was difficult to ascertain without a detailed audit process. 5% of the maternity notes have now been audited, and we have demonstrated that the introduction of an antenatal risk assessment tool, which is used at every contact, ensures that all women have an assessment in relation to the risks in their pregnancy, both physical, social and psychological, as well as an appropriate place of birth. This audit has been shared now by the audit team and is available should you wish to review. Immediate action 6 is around fetal wellbeing, arguably one of the most important elements of a safe maternity service. We now have a job plan for fetal lead, midwife and obstetrician in post, with an agreed syllabus in relation to the multidisciplinary team training that will be delivered throughout 2022-23, and this is compliant with the Saving Babies Lives Care Bundle. The fetal monitoring lead, midwife and obstetrician agreed that syllabus with the MDT, and that will be commenced next month. Immediate action 7 is around informed consent, and we've been working really hard with the comms team to develop our webpage to ensure that shared decision-making tools are available to all service users to underpin their choices in relation to their maternity journey. We've introduced particularly shared decision-making tools around some of the most complex decisions that women make in pregnancy around induction of labour and if they have a large baby. And as a result of this, we are now compliant with all elements in relation to shared decision-making and ensuring women have access to robust information to inform their choices. The final aspect of the Ockenden is around workforce planning. Obviously, as part of the papers, you will receive the quarter 1 and 2 staffing paper for maternity, which demonstrates our compliance with the Birth Rate Plus midwifery staffing establishment. And we have very clear workforce plans in terms of how we plan to grow both our unqualified and qualified workforce. The challenge to maternity service moving forward is that we've seen a sustained 12% increase in activity throughout the service over the last 18 months, with an increased acuity, which is demonstrated in our recent Birth Rate Plus report, which was published at the end of January. We're working with the managerial team to understand, with my professional judgment, what increase in midwifery establishment will be required at the end of quarter 4 to continue to safely manage the increased activity we see throughout the service. One of the most challenging aspects of the maternity workforce over the next 5 years will be around the age profile of the staff. And we've recently conducted, through business intelligence, a review of the age profile of staff in post. We have 59 midwives in the service over the age of 50, and we're working with the local HEIs around a maternity expansion plan to ensure that we are growing a workforce that will be able to manage the retirements in the coming years. And again, working with the internal teams in relation to the introduction of a maternity support worker apprenticeship scheme to allow them to be part of the calculated workforce as they have the correct skills, and also looking at the potential to introduce a midwifery apprenticeship within Northumbria, as there's currently no provision within the North East North Cumbria for that route of training. You will all see on a monthly basis our board level safety measures, an important element of the Ockenden to provide you all with the assurance and surveillance in relation to our performance that's shared with both the LMNS as well as yourselves, and details important clinical outcomes alongside other measures. So it's looking at not only the staffing in terms of the midwife to birth ratio, but also our dashboard performance in relation to clinical outcomes, patient experience, staff experience, and obviously feedback. And I'm very pleased to say that we did achieve all 10 safety actions for CNST Year 3, which was published last week.
Good. And I take it safety report, you've been through this in depth.
We have indeed. We have indeed, but Maura as well. If she should speak on this rather than me, because she is the safety champion in obstetrics.
Yeah, I mean, I think not to not to prolong the discussion, but I think we've really have gone a long way in a journey about improving maternity services in Northumbria, and we did, consciously there's been a restructure of the management team, and credit to Jenna who leads the team, the matrons. Marion and I work very closely with the team, and I have to say, it's a very positive team who want to see best practice across all of the services that provide in the county. I think it's fair to say we probably will have challenges. We've got more bookings than we've seen for some time. We've now got various reports. As you know, maternity is very well sort of national profile, so there are a lot of reports that will still give us, I think, some pressures, and we will have to make some decisions going forward. But I do think we're in a very good place, and I think a year on, I would certainly say we've looked at the CQC report that we did get last month. Ali and I had that conversation. There's some very good comms that come in. To be fair to Claire's team, they've done a really good support to maternity, and there are some really good aspects. So I think as a maternity safety champion, I do feel very assured It takes a team effort, but we're all obviously all up for that.
Alan?
Yeah, I agree with everything that Maura said. I mean, the one thing that's coming on stream very soon is that we're going to measure the quality of the babies that we produce. There's going to be a national thing called BadgerNet, where you actually we'll be able to compare ourselves across the country. And I think it'll be very interesting to see. I mean, I would expect that we will be better than average in the regional thing. The last time we measured, we were able to measure it. Given the service that we got, we were better than most. But we'll have some hard evidence as to whether it's working or not.
Good.
Thanks. Just 2 quick points. First point, I think the midwifery apprenticeship is really exciting, and to lead in the way in the region with that will be fantastic. Secondly, I think Jenna leaned over it around the staff experience. It's absolutely fantastic. In the most recent survey from January, with engagement of over 80%, and really high in the domains and higher above the trust average as well. So it's absolutely fantastic.
Lauren?
Yeah, and just to say thank you to Jenna and the team and Moira, because it is a real team effort, this. I just wanted one point, Alan, about recruitment. Several years ago, as Jim will know, it was very difficult to recruit into our area in the midwifery point of view, and the students weren't keen to come. Now we're absolutely inundated with the students. They absolutely want to come up with again. So I think that's a real good news story. Yeah.
Excellent.
Thank you, Chairman. It's just to say thanks to Jenna too. The team have really enjoyed working with the maternity team, and we have transformed the communications and broader engagement offer. And actually there's a lesson for other services from what we've done with maternity. And I think it'll be really good to see how we've used social media to really engage in patients. So much so, a member of my team is pregnant. She's enjoyed working with the maternity team so much. So she's just adding to your numbers there as going through the service.
An unusual outcome measure.
I'm sure it's not that what caused it.
It's a younger age group, of course, but I think the important points. But I think you've led the thing really, really well, and it's well overseen in safety and quality, and that's very much appreciated. But there's more to do. Obviously, keep it going, Jenna, and keep coming back. Thank you very much for what you do. Okay, Annie, patient and staff experience.
I'll start with the stories and obviously just assume everybody's had a chance to read them. Patient story deliberately chosen this month, Chairman, around someone with comorbidities, somebody describing the fear of returning to services again post-pandemic that we thought was relevant. A reminder that whatever your experience is, positive or negative, it stays with you and it influences your emotions about how you feel about accessing the service for the future. And also the patient reminding us about the importance of consistent and reliable communication on the ward, and actually how critical that is also when we aren't physically seeing relatives during the lockdown, etc. And then just linked to a really powerful staff story from Mary, Mary, a ward clerk, and the importance of a ward clerk in that coordination and consistency of care. And Mary spontaneously describing her role in family communication and the importance of compassion when relatives are distressed and finding them a quiet space to have a conversation. And also how frustrated she could get when she didn't have all of the information, some of the clinical information to hand, when she wanted to give that to relatives. But overall a really positive story about the transition from emergency care to high quality care on Ward 10 at NSET. The rest people will have been able to read, Chair.
Okay, good stories, relevant. Okay, and I guess the clinicians around recognise the fear of some patients coming into hospital after COVID. I certainly know patients like that. Yeah, okay, Nanny.
And again, so patient and staff experience reports, people have had a chance to read them just from a patient experience perspective to highlight a really strong performance in the last quarter and statistical gains in our real-time measurement, which we're continuing to see, which is encouraging. And just on the back of Jenna's results, really fantastic to see a top decile performance for maternity in the national survey, and that response from the team, given where the team were 5 or 6 years ago, it's fantastic to see that in a really tangible way. Staff experience, I'll flick through very quickly, but just a reminder, as I said earlier, we had a chance to get feedback from staff at some of the toughest time of winter. So if January was hard, we managed to hear from more than 4,000 staff. Again, that engagement, a proxy of the commitment of Northumbria staff, proxy measure in its own right, I think, but huge thanks to the business units for the way that they talk about the importance of this work and encourage people to respond. It's because we get those high level responses that we're able to analyse that performance in the way that we are, right down to team level, and understand teams that may need extra support. Overall, a consistent feedback around staff engagement that we measure every quarter, and again some consistency over emotional exhaustion, so no real concerns, but some general signs of less satisfaction around the job that you're doing, people feeling slightly more frustrated with the work they're doing. That's just statistical change, but again, not dropping off a cliff by any stretch of the imagination, given the demands described in Marion's board assurance report, and some of this data really quite encouraging overall. NHS England now, since July of last year, asked us to track employee engagement using their own measures, and we've seen some decline there, again not massive, but it is evident in our data. We've also seen more variation at a business unit level, so Elliot mentioned it earlier that certainly within medicine, within surgery, and within NHFM, we've seen more statistical variation reported by staff, and we want to pay attention to that. Usually there's a real consistency over the business units, and we haven't been able to distinguish, but I think the pressures of winter has certainly been able to bear some of that change out. These are the core measures of how we've underpinned our staff experience programme over time around these core domains. We've been able to track that and compare where we were when we started this work pre-pandemic to where we are now in January 22. Not a statistical decline overall, but some domains changing. That teamwork that we talked about earlier, that will be influenced by the number of moves with sickness and absence and everything else that COVID has had to chuck at teams. So declines in some area around the way that teams participate and come together and have a sense of being in it together. And also some changes in people wanting more opportunities to move on from COVID, to do some innovative work. And sometimes the context of a pandemic makes that kind of stuff more challenging to do. And some decline, again not massive, but evident in our data about how we feel about the work that we do and our jobs. And also an important area that I wanted to bring to the attention of the board. The first is the level of engagement. So we can, with the responses that we get, analyse that data with respect to groups represented by protected characteristics And in contrast to the national survey, where returns are quite in small numbers, we've heard from fantastic number of BAME colleagues, almost 800 staff with a disability, and more than 150 LGBT colleagues. So this is gold dust in terms of the numbers and data, and all of that a reminder that there is more work to do with respect to inclusion and belonging. So fantastic to see the strengthening of the staff network groups in the last 12 months. And it is because of that strengthening and their involvement that I think we're getting the returns that we are. But at every level, there is a difference for our staff, and we need to keep focused on that in a trust that is committed to being inclusive. That's a summary as quick as I can, Chairman. Happy to take any questions.
Pretty good. I did like the last slide with as you say, gold dust in there, getting such a large response, information and stuff we recognise, I guess. What did we?
I think overall, I mean, just huge credit to our teams. I think the level of resilience shown by Northumbria teams over the last 2 years is probably the biggest story in the data.
I think so. Ruth?
Just a comment, Ali, on the employee engagement data from NHS England and the point about initiative where there's quite a big drop. And are we hoping that I'm assuming that's slightly because of the rigours of COVID and people kind of feeling that they're put in a more controlled environment. So do we think our kind of innovation projects and things will get that back up?
I think people are really hungry for that, Ruth, if I'm honest. There's, when we had the Quality and Innovation Festival, we had teams coming together to say, we just really want to move on. A pandemic, by definition, has more command and control by necessity, and people in a culture in Northumbria where that's quite unusual. Actually, people have found that important, necessary, but not the way that they like to work, so they want to see that recovering. I think all of the level of the innovation work that's happening at the business unit is something that staff are quite hungry for, and particularly the opportunity to convene again, come together again, and be able to share their own ideas.
Good, thanks.
Yep. Anything else? What I really like about these reports is the going's tough. And you see it in the reports. If it didn't show it, we would worry. So negatives are to be expected, but also areas for action. And you've got that in the responses. There's no question. So it's really good. I don't know what we're going to do without you, but we'll have to do it.
Fantastic.
We promise you we'll do it well. Okay, thanks, Annie. That's really good. And gender pay gap?
Yeah, so I'm conscious. I'm conscious of time. Everybody's had the opportunity to read the reports. There's actually two here, one for the Trust and one for NHFM, because it's a private company, we have to report it separately. Just putting it into absolute perspective, this is really all about us employing more men than women at senior points in the organisation, and most of those men being well through the pay scales. So if you take consultants out for the Trust, it changes quite considerably, it reduces the pay gap considerably, that's what our report tells you. And the last page of both reports tells you what activities and changes we're going to try to make to improve the outcome. The NHFM one is almost a mirror image, other than take out consultants and put in technical staff, and then all the rest plays. And every other aspect of the gender pay gap report flows from that. That's it in a nutshell.
Okay. Any case?
I was just going to mention, Anne, around the Let have also done a gender pay gap report, and what that shows is absolute parity between female and male, so we'll see that historical change as they come through the ranks, so it'll be interesting to track that over the next 5 to 10 years and how that changes.
So I guess, I mean, my only question, you know, they are really good, but we're not missing anything here, right? You know, the focus on consultants, the focus on technical. You know, if you were a cleaner, or, you know, band 2, band 3, how do you see this? I mean, are we comfortable, are we sure that, you know, this is really fair?
Yeah, because Agenda for Change pays exactly the same to you whether you're a male cleaner or a female cleaner. But the problem is that there are more females who are cleaners than there are females who are consultants. It's actually as simple as that.
I get that. Just need to be sure, Claire.
It was really interesting on International Women's Day this year, where the Gender Pay Gap Institute, or whatever it's called, named and shamed some really high-profile organisations using social media and the media. When they were putting out proactive things to support International Women's Day, they then responded saying, yeah, but your gender pay gap is X. So it's really interesting, the emphasis it's putting on this in the public domain.
If you look at our gender pay gap in comparison to other NHS trusts, we're pretty good.
Okay, good. Everyone happy with that report to approve? Yeah. Okay, item 4 now, 4.4 is board walkabouts, so we've got Maura doing Northumbria.
Yeah, I mean, it obviously shows really the report that we've just had from Jenna, which shows it's a very good atmosphere. I visited on just really, I was going to say, is the staffing situation had probably just eased a little bit because they'd had a tough 4 weeks, 5 weeks where they were very short with staff being off sick or isolating. So I visited the whole of maternity at Northumbria that morning. There was a very good feel around us, made the opportunity to speak to newly qualified midwives, student midwives, people who've been there a while, and you know, previously midwives usually quite forthcoming about comments, and usually they would say, oh, this has not been very good, or the meals haven't been good, or the whatever. And there was actually very little that I needed to follow up. And in fact, the opposite. They were very pleased to have the new centre, the Wellbeing Centre, and I took the opportunity to have a look down there when I was in Northumbria, and they said that yes, it had been difficult. Yes, they'd all had to do different ways of working, they had to cover each other's colleagues, but overall they really loved their job and enjoyed working at Northumbria, so couldn't say much more.
Excellent, good. And we got Alan and Phil. Phil, you leading?
Yes, happy to do this one, Chair. This was my first hospital walkabout, but thoroughly enjoyed it. We went to 2 areas at once, but the community child health was fairly quiet, but we did have quite a good discussion with the senior nurse, Kate Greenwood. One thing which we did pull out on the commentary when talking to them about what they could improve on and so forth, the respite care is a very valuable service they provide, but it tends to be restricted to about 3 hours a month for families, and so we just questioned whether there was an opportunity to try and do some more of that, because it no doubt is an excellent service. It's not easy because obviously you've got to have people who are trained to do it in the right way, but because it's such a valuable thing to do, we thought that was worth exploring. We then also had a look around the labs, and again it was quite interesting. Haematology, relatively quiet. When you got into toxicology, it was quite noisy, but as we said, it wasn't the staff that were making the noise, it's the machines. And it can be a little bit difficult for them from time to time. And again, one of the things when we potentially look on the relocation of the labs at the new site that they're looking at the moment would be to try and address some of those noise issues. But seeing a very strong team, well motivated and doing some excellent work. It was a good visit. Alan.
Yeah, may I just add something about the charity thing and try to encourage people to mention the charity when you do walkabouts. I mean, there is a possibility that the charity might be able to help with this respite care bit. And we also asked, the community child health, whether there's anything else that they would want. The one thing which isn't in this report from laboratories was that They are currently getting new machinery, particularly for point of care testing. And I wondered about the possibility of the old machinery, which is still working, whether we might look into putting this into the Tanzania project, which we're all working with, and I've put them in touch with, or I'm putting them in touch with Richard Walker, who runs the Tanzania project, as to whether there's any way that we could move our machinery out there. I mean, it may be that there's not, because of, maybe more machines that you need reagents which they can't get. But certainly worth exploring. So I just encourage everybody that's doing boardwalk events to think about what extra this vast sum of money that we used to have in the charity before it was used for other things. Whether we can use it just to enhance them. And generally, it's a surprise to people that we're offering this money, encouraging them to apply.
Get our message out, Jeremy.
Just to say that when you walk into that lab at Wansbeck, what you don't realise is you're walking into a north of England forensic toxicology service that's absolutely amazing. I think when you think about where it is, it's great credit to the staff. They are very well recognised in their field, and it's something I think we should cherish. I mean, they have got a lot of expensive kit you bought from Bijou. It's been used.
Yeah. Do they feel cherished?
Oh yes, no, I think so. I think they it does, but with ambition as well.
Absolutely. We've got professional recognition as well, I guess.
Okay, I did a couple of walk rounds too. I went to Wansbeck, essentially on an estates thing. So the first thing is the new front door, which is at the back end, so the south entrance coming. So we need to think hard about that. Make it a friendly place, but they've got the right ideas. There's still 3 or 4 options, I think. I really wanted to see the Walton ward is refurbed, because remember we moved that from Morpeth about 2 years ago. It's really good. There weren't many patients in it yet, but it looked much better. Loads of space for storage and relaxation for the patients in there. So I was encouraged by that. Really good. And the other thing I wanted to do was just speak to the ANIC people who were sent there for 3 months, but it's more like 6 months. So I felt guilty about that. I wasn't allowed through the door because they had COVID. However, the sister came to the door and sort of expressed thanks on behalf of the board. To a person, I met a few nurses and a couple of doctors. They're smiling and they're happy and they're positive, pleased to see us. No question about that. So from a personal point of view, it's really good. The thing that really struck me, though, looking around the estate, interestingly, the well-being possibilities in your central records space is really as good, I think, as in Northumbria in passing. But the gardens, some of the gardens are getting shabby, and I think there's something maybe the charity could do out there. And someone was suggesting an opportunity for volunteers around that as well. So it was a really good estates visit, good mixed visit. I also went to Northumbria to look at the discharge lounge, and that's an amazing place. So that's on the 3rd floor of the new build, and it's quite different. I mean, I was thinking armchairs, so there were armchairs, but one of the team again, smiling, positive. Thelma made, and she just gave the space to Jenny, I think it was, and this woman, and you'd be so proud of her. She must know every nursing home, and everywhere she could put a patient. She knows where people live and what they need when they go home. And she's in contact. She knows not to ring the nursing home on this shift because the answer is no. But you wait half an hour, the right person will be on the answer yes. I mean, working for us, and I mean, fabulous. And she wasn't sort of gross about it, just the way she was. And it was just worth seeing. But the thing that really struck me when I was talking to the team at the desk, we've been talking about flow. This is a flow project. It's about freeing up about 9 beds a day in A&E, and so patients can move in and be diagnosed more quickly downstairs. And they got it. But the real message is that these are little things we keep doing the whole time. When I first joined, you were talking about flow. It never ends. It's really just
But you know, it's really enlightening. And I saw the Wellbeing Centre downstairs, and as Moira said in their report, it's absolutely amazing. If you haven't seen it, go. But that's it. Very, very worthwhile from my point of view. Andrew?
Yeah, so Alistair and I went last week around radiology on Ward 24 at the Tyneside General. So radiology, we kind of turned up at lunchtime when I think the morning rush had just calmed down, but there was a big theme around how they're getting busy and expecting to get busier, and they're already working till 8 o'clock at night, and they're already working the weekend, so they were kind of really conscious about the direct access reopening again soon. And it was sort of, it almost felt to us a bit like the calm before the storm in a way. They were confident about it, but it was just a sense of things changing, and they'd obviously, you know, still having to do the sort of social distancing through the waiting areas and that kind of thing was just a bit of a struggle, but they were kind of getting through it, I guess is the way to say it, and everyone was staying positive about it. It's definitely a thing. The big activity that was going on was the builders were in for installing the new scanner, and I think that has just created a brilliant sort of impression with them that not all the investments going on at NSEC, and Debbie that was showing us around really sort of emphasised how much it had sent a message that we're investing in the base sites and how important that was. So I thought that was worth relaying back, and they're very excited about having that in the hospital, and kind of conscious that other places are sort of sticking these things in shopping centres or whatever, and they actually really feel that the offer will be better because it is in the hospital. So I thought that was good. We had a chat about how the scanners are now getting connected up so that people who are elsewhere, colleagues that need to be brought in for whatever reason, can help set up scanners, look at images without having to be on site. And so that was quite an interesting thing about working in a more flexible way or not having to have people travelling around. So that was going down well. It'll be interesting to see how that goes. And we had a conversation about flexible working in general, which was quite interesting because it chimed with, we had a big discussion just immediately before then at Workforce Committee about flexible working and what that looks like in the future. And Debbie was saying, well, you know, a lot of her job sort of could be done from home, but actually it's really important to balance that with the need to be there on site, and how she didn't really want to do it from home. And just that, it just chimed with the conversation we'd had that morning about some of the subtlety around that. So good input there, and I think a really good walk around. We went up to Ward 24. I was really conscious that we sort of turned up unannounced. It was lunchtime, it was very busy, lots going on, so we were quite kind of gentle, if you like, but everything was obviously running really smoothly, even though it was super busy. They seemed tired, so it had been a COVID ward, and I just thought there was a sense of, I think somebody said before about, you know, still smiling, but there was definitely a sense that it had been difficult. Some of their colleagues had been off sick as well, and the thing that really struck me was just how difficult it is when you've got COVID patients who are also at risk of falls. So they had several staff who were really just tied up on falls watch, but doing that in the bay where the COVID patients were being isolated. And it just made it, even though the staffing numbers were fine, it just meant that everyone was really having to sort of step up to make it work. So I'd heard of that before from our conversations, but it really brought it home to me seeing what it was like in Ward 24. And we bumped into the activity champion as well, who was kind of, you know, this is obviously the highlight of people's day in many cases, isn't it? So the pensions are often there for a week maybe in Ward 24, and it was just brilliant to see that in action and just see how positive an impact it has, and just really being a kind of highlight of the day for people. So it was interesting. I asked my favourite question, which is almost my favourite conversation starter, where we've been standing in front of a nerve centre screen on the wall for a while, just going, so you know, how are we doing with this then? And it was funny that Claire that was showing it round said, well, we're getting used to it, in this sort of slightly awkward way that people do answer that question, but she actually had the remote nerve centre thing in her hand, and it was glued to her hand, and she clearly used it all the time and was quite confident with it, so I thought she might have kind of given a more positive answer, given how she was obviously doing really well with it. And it was a good prompt to just have a chat, because I said to her, well, what would make a difference? You know, what would help? And she said, well, actually just having some more mobile devices would help, because we all share these at the moment. So it's a useful way to tell her that we're looking at the mobile device strategy, and we're looking at giving people devices that are their personal devices and they don't have to share them. And she was really happy to hear that, and it obviously would make quite a big difference to them. So that was good. And then final thought was, a lot of her, this is Claire I'm talking about that was showing us around, a lot of her sort of tricky times at the weekends and evenings come from around the visiting rules where she's there. You know, she's talking about situations where people have maybe travelled up from London, they're driven from London to come and visit an elderly relative, and then they don't understand why they're only allowed an hour when everywhere else in the world is in some way pretending everything's back to normal. So there's definitely, I think, you know, we knew about the disparity, but the thing that brought it out to me was just how much work colleagues have to do on the wards to explain it to people and sort of enforce the policy and try and explain it and keep things running smoothly when it's hard for visitors to get their heads around it.
Good. Okay, some really good points in all of that. Thank you, Andrew. Any comments, reflections? Good. It's good grounded stuff, and I'm just so pleased we can get out and about. And there's other things we need to do. 15 steps is running. Place visits might reappear for governors, which would give them. We've got governors who've never been near a ward yet, and they're quite anxious about that. Rightly so. Annie?
Just from a staff experience perspective, how much the lab staff will have appreciated the visit. We can get the story about it's easy to be forgotten sometimes in a system and feel that you're in the bowels of an organisation. So having a visit like that would have meant a lot.
Yeah, I think they were generally interested in telling you what they were doing. Some of which was beyond me, but you could tell it was good stuff they were doing. So it was a good visit.
Yeah. Can I just say that that is interesting because Martin came with me to the labs last year at NSEC, and we know that Wansbeck were wondering when your visit was going to take place. So it was really nice, and that wasn't predetermined or anything, but the feedback was actually they're going round everywhere. So it's really good.
I knew there were some wards closed, so I deliberately chose some non-ward area. Jane, you got caught out by that.
It did remind me though that I think one of the things they said that they were really looking forward to was the centralisation onto NSEC, because there is a good team spirit there, but obviously it's a bit more difficult being spread out. So I think that centralisation will help it even more.
I think it's firming for ourselves. Keeps us all.
See that?
That's when he signed the paper.
You said it wasn't a problem.
Sorted out outside. Right, good. It keeps us grounded, that's really good. Keep it going. Don't know where you'll go next, but I look forward to receiving those reports as well. Right, under item 5, we've got a number of items there. 4 items just starred. That means they're being through board committees in some depth. And I just suggest we receive those unless there's comments on any of them. Are we all okay?
Chair, can I just mention current year, really positive forecast. You mentioned in the opening remarks about inflation, etc. So that is an issue. The board we discussed it FIP on Monday, so we just because recognise that's going to be a particular pressure, particularly around energy.
Yeah, we need to talk about dashboards and things like that, I think, going forward, so that we've got those things right in front of us. So we'll move very, very quickly, I think. Right, so item 6 says agenda for the next meeting, which is there. I want to say, but it'll probably change by the time we get there. We've got a review of the meeting. Did everyone have a chance to contribute what they wanted to contribute? Time, space, enjoy other people's contributions. Is there anything we might have discussed at this point that you thought we should? No? Martin?
So just for my chair, just worth feeding back to Simon and Elliot. I think you already said it, it's just worthwhile their honesty and realistic assessment of where we are, warts and all. So really positive stuff in there, but it's that honesty which certainly from my point of view I appreciate.
Yeah, absolutely true. And I mean throughout the trust, and Jim said it last night, I mean some of the statistics we've got are not as good as we would like. But they're a lot better than most other people have. But we're just driving on, and I think the evidence from those two professionals was just amazing. That they're driving hard on a broad front. I mean, both of them, you know, breadth, and just amazing, absolutely amazing. So yes, you're right. Right, we've got a couple of members of the public. I'm not sure if they're still there, but this is an opportunity for them to comment or ask a question. No, they're gone, I think. Okay, so that's it. We'll declare this meeting closed. Thank you for your time.